Anna Kate, you're muted.
Can everyone hear me now? Okay, sorry for the few little technical hiccups here. We're just about to get started. If you're just joining, feel free to hop in the chat and let us know where you're joining from, and we'll get started here in a minute. Looks like people from all over Arkansas and beyond. It's great to have you. All right, well, I'm going to go ahead and get started. So my name is Anna Kate Bogards, and I'll be your webinar moderator for today. Welcome to our webinar on early childhood trauma treatments, how to decide amongst CPP, PCIT, and TF-CBT, led by our own Kelly Hammond, Karin Vanderzee, and Alyssa Wilburn. Before we get started, I wanted to just do a few housekeeping announcements, and then we'll turn it over to the webinar. Arkansas Building Effective Services for Trauma, or ARBEST, is a state-funded program at the UAMS Psychiatric Research Institute, and our aim is to improve mental health services for children and families who have experienced trauma. We work really closely with multiple partners throughout the state to build a more trauma-informed state. And we're probably best known for providing training to mental health professionals on treatments that are effective with helping children and families recover from trauma, such as the treatments that you'll be hearing about today. So stay tuned for that. A few housekeeping announcements. If you have a question throughout the webinar, please make sure you put it into the Q&A. I'll be keeping my eye on that Q&A, and that's where we'll see your questions. Feel free to put those in throughout the webinar, and we'll take some time at the end to get to your questions. If you put your question in the chat, we may or may not see it, so I really encourage you to put that into the Q&A. But feel free to use the chat throughout, and we'll be, engaging with that as we can. So if you're interested in earning a CEU, just be sure that you stick around to the very end, and we'll make sure that you get all the information you need to get that CEU. We are recording this webinar, and we'll put it up on the ARBEST YouTube channel afterwards, where you can find all of our previous webinars. And that is about all I have for housekeeping. So I am going to turn it over to Kelly, and I'll let you guys introduce yourselves and get the webinar started.
Thank you, Anna Kate. Just if somebody could give me a thumbs up to let me know you can hear me okay. Great. So we are going to get started, and I'm going to move pretty quickly through the first part because we have lots of fun stuff to discuss. And I want to make sure we've got lots of time for that. Anna Kate already told you in her introduction what ARBEST is, and I'm a member of that team. I'm also a licensed certified social worker. As we've been doing more and more work within our program with ARBEST and sort of disseminating and teaching folks about evidence-based modalities, particularly for young children, we kind of came up with or encountered a new problem, which is also a good problem, and that is one of having too many tools or more than one tool, and then needing to have a way to decide which tool to use and which would be the best fit for our children that we see in clinic and their families. And so as this kind of progressed with time, we wanted to offer a framework that we have found helpful to determine what tool that you might use when you have more than one option. in terms of what might work and what might be the best fit. So we are going to get started. First of all, with our objectives, we hope to help you understand guidance from treatment developers and experts regarding circumstances under which it might be appropriate to select either CPP, Child-Parent Psychotherapy, TF-CBT, Trauma-Focused Cognitive Behavioral Therapy, or PCIT, Parent-Child Interaction Therapy. We want to help learn a decision-making framework for supporting mental health clinicians in selecting amongst these evidence-based interventions, as well as to apply decision-making framework to a clinical case. So first, before we dive in, we want to begin by saying equifinality. That is the term that we use to demonstrate that there is often more than one pathway to the same outcome. And so we know that many of you on this webinar are trained in one or more of the evidence-based interventions that we're going to talk about today. And some of you might even be trained in others that we're not going to talk about. So the absence of one that you might be trained in is really a byproduct of what we are able to train throughout the state as part of RBES. So our goal is to introduce you to a framework for deciding amongst EBTs, evidence-based treatments, not really to convince you of one treatment over the other. We're just happy if you're using evidence-based interventions. This is really an overview of how to decide when you could choose between more than one. But first, a little bit of bragging. This is a graphic to show what we have accomplished through the RBES team and training so far. Over 140 of you all are trained in more than one evidence-based treatment for early childhood trauma. You can see that first one is TF-CBT. It's most widely disseminated. It's also been around the longest as far as our ability to disseminate in the state. And then we have CPP and we have PCIT. And what I think is really wonderful about this slide is that we have evidence-based treatment trained therapists in 68 of our 75 counties of Arkansas. And so we are doing really, really good work to be able to provide for and meet the needs of kids in our state who've experienced trauma, as well as their families. So we're going to get on the same page about our 3 EBTs that we're going to talk about today. Remember equifinality. We're covering these 3 because they're ones that we can disseminate throughout our state through RBES. So trauma-focused cognitive behavioral therapy, TF-CBT. This is evidence-based for children ages 3 to 17, 18, who are experiencing significant emotional problems that might be PTSD, fear, anxiety, depression, but they're all related to traumatic life events. They do not, however, the children who we see for TF-CBT have to be diagnosed with PTSD to engage in this treatment. This model is structured and directive. It's components-based, and we use the acronym PRACTICE. So we have psychoeducation and parenting, relaxation, affective modulation, cognitive coping. Those are called the PRAC skills. They're sort of your foundation. Coping skills are learned here. We're also going to use really good gradual exposure throughout the PRAC skills, leading up to trauma narration and processing, during which the child will tell a narration of their traumatic life events. This is to help prepare for and gain mastery over any trauma reminders, to resolve any avoidance that might be lingering, identify and correct cognitive distortions, as well as contextualize trauma experiences. We may also need to do in vivo desensitization for any of those things that are kind of lingering out there, avoidance laws that are keeping kids from getting back into their typical developmental trajectory. And we'll also have co-joint sessions and enhancing future safety throughout the application of the model. We would expect to see 12 to 16 weekly sessions, although that might be closer to 20 to 25 for complex trauma presentations. We also have parent-child interaction therapy, PCIT. This is evidence-based for children ages 2 to 7 with behavior problems as their most significant presenting problem. However, it has been shown to help with trauma symptoms. It's also structured and directive. It involves real-time coaching, including a bug in the ear and a therapist behind a one-way mirror, typically. And it has 2 phases, CDI, child-directed interaction. The goal here is to strengthen the relationship between the parent and child through child-directed play. Caregivers learn a variety of skills to promote positive relationship with their child and strengthen social and emotional development. And this will all go into making the second phase of PCIT a little easier, hopefully, and also more effective. That second phase is parent-directed interaction. This is where clinicians help caregivers implement consistent, predictable commands with follow-through using a structured timeout procedure. This will serve to support the relationship by helping caregivers learn to manage any challenging behaviors their children might be experiencing. And that can all be the result of trauma symptoms. It also helps to reinforce children's understanding of their caregivers as dependable and predictable, safe adults. We would expect to see 16 to 20 sessions. However, it is not time limited, but criteria based in duration. And then we have CPP, Child-Parent Psychotherapy. This is evidence-based for children birth through 5 years old with traumatic stress, behavioral, attachment, or other mental health related issues. The overarching goal is to support and strengthen caregivers, the caregiver-child relationship. This will help restore the child's sense of safety and can help with improving the child's cognitive, behavioral, regulatory, and social functioning. This approach is reflective rather than directive. It gives us a framework to follow rather than a manual. It involves 3 phases: a foundational assessment and engagement phase, during which we gather information about the child and caregiver, trauma, symptoms, overall functioning. Then we have the intervention phase. This is when the therapist facilitates caregiver-child interactions through which the dyad can become more attuned and regulated. It fosters a safe, secure attachment. And then we move into termination. And during this phase, the therapist, caregiver, and child process the end of the therapeutic relationship. This will help foster non-traumatic goodbyes and helps to maintain progress that's been made within the dyad. We would expect to see 20 to 26 weekly sessions. However, this is not time limited. It's based on the needs of the dyad. All right, so that was a quick overview of the 3 interventions we're going to be using for today. Please remember, we're only sort of talking about these 3 because they're the 3 that we're able to disseminate. Others would probably be applicable with this framework as well when you're trying to decide amongst interventions that you've already been trained in. So let's talk about the framework. Just as a reminder, when we started doing more and more trainings in these 3 evidence-based interventions, we started to get questions about how to choose. So our team, which consists of trainers for CPP, TF-CBT, and PCIT, met together. We tried to come up with the framework. And just to give you context, most of our trainers are trained in all 3 of these EBTs, and all of the trainers are trained in at least 2. So as we were considering aspects of this framework that we would want to include, we were really thinking specifically about these 3, but again, probably applicable to any other EBT you might be trained in. So after reaching a consensus about the factors that really influence our thinking within our team, we also sought out literature to seek guidance from other experts in the field, like the treatment developers, national trainers, researchers. And it's really tempting to say, if only we had a flow chart that we could follow. And yes, that would be lovely. And as I'm sure you're all aware, the majority of the families that we work with have complex issues and complex factors that need to be considered simultaneously. And so a simple flow chart really didn't reflect the decision-making process that has to happen when we're deciding what intervention to use. So hopefully you have a handout. If not, we'll provide it to you. For the factors that we want to consider when we're thinking about what intervention to choose, there are 3 major like overarching categories that we would consider. They include the child, the caregiver, and the environment. So when we're thinking about factors to consider for children who are involved in treatment, we would want to think about the things listed on this slide. So what is the age of the child? What's the developmental level of their speech and language? What's the physical size of the child? And is the caregiver able to sort of move the child if needed, based on the child's size and the caregiver's presentation? the types of symptoms and which are most impairing, the timeline of those symptoms, and if there have been any changes over time, as well as are there verbal memories of the trauma. We would also look at considerations regarding the caregiver. What is the availability of a supportive caregiver to participate in treatment? Does that treatment allow for offending caregivers to participate? Offending in quotes, because that differs. The definition of offending caregiver can differ amongst these interventions. What's the primary concern of the caregiver and the level of impairment of any of the caregiver's symptoms? Specifically, is the caregiver able to hear about the child's trauma and tolerate that distress? And then finally, any environmental considerations. So we want to look at placement stability, the case plan goal, visitation frequency, if it's happening, and how did the child's symptoms change or not change before, during, and after those visitations. Any other trauma treatments that are used within the family, and then cultural considerations that influence the fit of the model with the child. So that is our overview. I'm passing it over to Dr. Wilburn to walk us through specifically what this framework looks like in each of these interventions.
Thank you, Kelly. I'm just gonna do a little screen swapping here. Okay, can someone tell me if the PowerPoint looks okay from your end? Okay, thank you. Okay, so during my section, I am going to walk us through the framework that Kelly outlined for us and go through each of TF-CBT, PCIT, and then CPP. There's going to be a lot of information during this section, so I will do my best to present it clearly and also concisely. So just so everyone knows, the wording that you will see on the next several slides that's in red represents those components of the framework that Kelly just outlined in those child, caregiver, and environment categories. So starting with TF-CBT, in terms of age, we know TF-CBT is appropriate for children ages 3 through 18 who have experienced or witnessed any type of traumatic event. Here, a child's speech and language development must be equivalent to a 2.5-year-old and have a verbal memory of a traumatic experience, or to some degree, have the ability to express that memory in some way and the impact of that experience. So even though children must present with symptoms of traumatic stress related to some type of experienced trauma, they do not have to meet criteria for diagnosis of PTSD in order for TF-CBT to be an appropriate treatment here. In addition to symptoms of traumatic stress or PTSD, we know it's really common that children would present with other emotional, behavioral, or maybe social relatedness symptoms, which may have occurred before or after traumatic events, and might be explained by a diagnosis of PTSD. Sometimes too, the failure of a child's environment or support system following a traumatic event might be contributing to some of the symptoms that we're seeing. For example, we might have a caregiver who has become overwhelmed in response to the experience that their child has had, and maybe they have more difficulty setting limits and have become a little more permissive in attempt to not overwhelm the child more or cause any further upset. But we know sometimes when that happens, we actually see an increase in behavioral challenges in kids. Really, what we want to pay attention to is that traumatic stress symptoms should be causing kind of the greatest impairment. That should be the primary treatment concern for us to move forward with TF-CBT. On the other hand, though, if there is a child who is presenting with comorbid symptoms that we know maybe preceded a traumatic event. So for example, if we have a child who was presenting with some behavioral challenges before a trauma experience, and that maybe that trauma exacerbated those behavioral challenges, it would be important to kind of consider how much of those behavior problems might interfere with even moving through TF-CBT. We might want to consider addressing kind of the behavioral challenges first before moving into TF-CBT. Okay. So in terms of caregiver factors for TF-CBT, really, any primary caregiver active in a child's life can participate in TF-CBT with a child. So this might be a biological parent. This could be a foster or adoptive parent, or maybe extended family member. The caregiver who participates must be generally stable, safe, supportive, and available to help the child apply the skills that are learned in sessions. TF-CBT can be implemented without a caregiver if one can't be identified. Sometimes we see that in cases where kids are in foster care and they don't necessarily have a primary or stable kind of adult identified to participate. We can still proceed in TF-CBT, but what the research data suggests is that we might see some improvement in children's traumatic stress symptoms when we don't have a caregiver involved, but we might not see improvements in disruptive behavior. Another factor that we want to consider is the primary concern of the caregivers. So some caregivers might be most concerned about a child's post-traumatic stress symptoms, but others might be concerned about the behavioral symptoms and their ability to manage them. So in these cases, within certain components of TF-CBT, for example, that parenting component, we might want to emphasize a little bit more kind of the behavioral concerns and frame our treatment in that way in order to kind of meet the needs of that family and communicate that we're trying to address kind of their primary concern. It's really important to note here that TF-CBT is not designed to be used with offending caregivers, except in very rare cases. So the guidelines for these types of cases is outlined in the TF-CBT for Children in Foster Care Implementation Manual, and you can find that by Googling that online. So offending caregivers are not typically included in TF-CBT and never in instances where a caregiver physically abused, sexually abused, or neglected the child. Okay. Caregivers who share a child's trauma history, such as in cases of domestic violence or traumatic loss or car accidents, or maybe have unique but similar trauma histories, may experience reductions in their own post-traumatic stress symptoms by participating in their child's TF-CBT. But some caregivers may be really impaired and have their own mental health symptoms and distress that it makes it difficult for them to focus on their child's treatment. So in these cases, providers may want to consider encouraging caregivers to seek out their own individual therapy services so that they could potentially be more effective and more effectively involved in their child's treatment. So in order to proceed with TF-CBT, the child's environment should be fairly safe and stable. So for example, if we know that a placement change is about to happen, we might delay starting TF-CBT until that child is in the new placement. However, and it's often the case that children are kind of in like situations where they could potentially have a placement change, but we don't know when that might happen. So in those cases, treatment developers just recommend starting TF-CBT because it's possible that starting treatment will actually help stabilize that child and potentially prevent any placement changes. So for children in foster care. Non-offending caregivers may proceed with participating in TF-CBT regardless of the case plan goal or visitation frequency. But we might want to consider the manner in which TF-CBT is implemented, depending on whether visitation is ongoing. Whether the child's biological caregiver is meeting requirements of the case plan, or maybe reunification is likely. So a provider would want to monitor kind of the impact of those visitations for that child, and really help whatever caregiver is involved in that child's treatment kind of discuss the impact that those visits might be having, and help sort of support that child before, during, and after visitation. I'm actually going to put a pin in these last two bullet points, considering kind of other trauma treatments that are being used within the family and cultural considerations. I'm going to come back to them a little bit later. So PCIT is typically appropriate for children ages 2 through 7. But here, the developmental level of the child with regard to their speech and language is actually more important to consideration than the child's chronological age. So the skills that are taught in CDI, that first phase of PCIT, are appropriate really for use in children beginning in infancy. And there's lots of variations of PCIT that have been developed, for example, for infants and toddlers and for older children. Some have kind of more ongoing research that's still being, that's in progress for those modifications. But to implement PCIT as described kind of in the standard manual, children need to have the developmental capacity to understand if-then commands. And we know that typically develops around 24 to 30 months of age. With older children, an additional consideration is the physical size of the child, because we know a lot of children initially refuse to comply with the timeout procedure and commands that are given in session. It's frequently necessary for the parent in treatment to carry the child to the timeout chair or the backup area. So here the child needs to be small enough for the parent to lift and carry the child. In other cases, when we have maybe a physically larger child, therapists might consider using an alternative procedure, maybe kind of a hands-off timeout modification. In terms of symptoms, PCIT is appropriate when a child has clinically significant externalizing behavior, again, which may have developed prior to or after a child's trauma. And so PCIT does not include direct processing of trauma experiences, so it's really not necessary for the child to remember the trauma or be able to discuss it in any sort of way and its impact. As I talked about earlier in regards to TF-CBT, a child's disruptive behavior might make participating in other treatments more difficult. So again, we would want to consider here, is PCIT an appropriate treatment to start with to address some of those behavioral difficulties? And will that make participating in TF-CBT later on more feasible? So in terms of caregiver factors for PCIT, PCIT is inherently a dyadic treatment, so it involves a caregiver by nature. And so here a caregiver is broadly defined. This can be any adult who has regular kind of a long-term caregiving role for this child. So again, we might consider biological parents, foster and adoptive parents, and extended family members who provide maybe day-to-day care for the child. PCIT is most commonly conducted with a caregiver who that child lives with, but it's ideal if we can include all the caregivers that are involved in a child's care, just so that everyone is on the same page. PCIT is not recommended for use with caregivers who have sexually offended against a child, but can be used with caregivers who maybe have perpetrated physical abuse or neglect. In fact, there's a lot of studies that shown that have shown significant reductions in physical abuse risk factors or recidivism following their participation in PCIT. In situations where there's multiple symptoms present, again, we want to consider what is the caregiver's greatest concern. And so, for example, a therapist might see a child's separation anxiety and those symptoms to be kind of clinically significant and a target for treatment, but maybe the caregiver views the behavioral difficulties as the greater problem. We know that treatment is likely to be more effective when caregivers feel like their concerns are being addressed. So that really might lead us to proceeding in PCIT and focusing on those behavioral concerns. Unfortunately, we know that intergenerational trauma is not uncommon in families that are receiving PCIT, and parents actually can derive sort of secondary benefit and increased stability and self-efficacy that PCIT provides. But because the primary focus of PCIT is child behavior management, as opposed to any kind of parent symptoms, again, we might want to consider, do we need to refer or encourage caregivers to seek out their own services if we feel like they have their own kind of mental health symptoms that might make it harder to participate and be fully engaged in PCIT? Okay. Again, here, the stability of a child's placement is a really important factor, even for PCIT. So because PCIT focuses on strengthening that caregiver-child relationship, it really shouldn't be conducted in situations where there is a relationship that's very likely to end, such as a foster care placement that's known to be short-term. It would not make sense to start PCIT with those caregivers. Similarly, in situations where a parent has lost custody, it would not be appropriate for that parent to participate in PCIT. It's really only appropriate if there's a case plan goal of reunification with that parent. However, a different caregiver can still participate with that child. Even when the goal is reunification with the parent, that parent must have sufficient contact with the child to conduct and practice PCIT. So at a minimum, that parent must be allowed sufficient unsupervised contact with the child so that weekly therapy appointments are even possible. And because that outside session practice with special time is really a vital part of PCIT, it's recommended that that parent have at least 3 visits per week in addition to the therapy session. And ideally, those visits should take place in some home environment so that that parent can practice those PCIT skills. Okay, moving on to CPP. CPP is designed to treat children under the age of 6. And so by nature, due to its ability to treat children starting at birth, there are no minimum developmental requirements or physical size considerations for participation as far as the child goes. Developmental considerations are made when provider is delivering CPP to a family. So there's different therapeutic techniques that might be used just depending on the age of the child and the developmental stage of the child. CPP is designed to treat emotional and behavioral symptoms with children who have been exposed to trauma, with an additional treatment goal of returning child's development to a more typical trajectory. If there are known delays. So a timeline of symptom presentation and kind of associated trauma exposure is often really challenging to establish in young children. We know that there are some kids that have experienced potential trauma in utero, such as when there's been maternal substance use during pregnancy. So to move forward with CPP, it's not necessary to establish that current mental health symptoms emerge prior to trauma or following trauma. That's not necessary in CPP. Importantly, a fundamental tenet of CPP is that memory starts at birth. And pre-verbal memories have an impact on child functioning. So a child does not need to have the ability to verbalize trauma memories in order to participate in CPP, but they may use play to communicate pre-verbal memories. Because CPP inherently can treat kids birth through 5, we might be seeing some infants in treatment. And so really we would not expect an infant to verbalize any trauma, and that's not necessary here, even for older children, although we might see them again play in the context of session, any kind of memories they have of trauma. And then throughout CPP, caregivers and children are also learning to identify and respond to kind of body-based dysregulation and other impacts that pre-verbal trauma may have had. And so the provider is really working to address those kind of throughout the course of CPP. So similar to PCIT, CPP is inherently a dyadic intervention. So it really necessitates the involvement of a caregiver within treatment. And CPP is practiced within a relationship-based framework where the primary vehicle for change is that parent-child relationship. So during that initial phase of CPP, the clinician is assessing the needs of each caregiver-child relationship with the understanding that child symptoms and their attachment are really relationship specific, and there might be different needs within each caregiver-child dyads. The nature of the caregiver who participates in treatment really varies based on the presenting needs and the stability of placement. So within CPP, we can have biological parents, we could have foster and adoptive parents, or other adults that are providing significant caregiving for the child. It's often the case that children are potentially having a couple or few sessions kind of ongoing at the same time with different caregivers. The clinician establishes really whether a child is able to participate with a certain caregiver in CPP during that first phase. And we're really wanting to consider a lot of different factors here. For example, the stability of a caregiver and their mental health symptoms. We are wanting to kind of assess whether a caregiver is able to acknowledge that the child has a trauma history. For caregivers who have perpetrated abuse or neglect, they still might participate in CPP, but we want to assess kind of their degree to which they acknowledge their role potentially in their child's trauma exposure and symptoms, and really assess whether kind of that current safety within the dyad. The presenting concerns of the caregiver are kind of obtained in that first phase. And again, we're really wanting to frame some of the symptomatology in the context of the trauma. And again, it's common for caregivers to participating in CPP to endorse post-traumatic stress or maybe other kind of mental health related symptoms, in addition to other potentially high-risk behaviors, such as substance use. And so we may decide to not proceed with CPP if a caregiver is not agreeable to kind of the treatment model where we're having those dyadic sessions. Again, if they're not able to address the child's trauma history, if their mental health difficulties are posing any kind of safety risk for the child, if they have like untreated psychosis, or maybe they're unable to attend sessions sober. Those are some examples of things that we'd want to consider where CPP would be contraindicated. And CPP may be contraindicated if a child is currently in an unsafe home environment. So, for example, in cases when a child has ongoing contact with a violent caregiver, or a caregiver who is denying that a child has experienced trauma. But CPP has successfully been used as part of the case plan for child welfare involved families. and has actually shown high rates of parental reunification and lower rates of placement disruption. So if the goal is parental reunification, the CPP clinician might choose to begin with CPP with the biological parent and the child. But on the other hand, if the goal is termination of parental rights, the CPP clinician may choose to begin treatment with the most stable caregiver, and that might be a foster parent or pre-adoptive parent. There's no minimum visitation requirement related to a caregiver's ability to participate in CPP. Really within CPP, a clinician is recognizing that attachment is built over multiple interactions between a caregiver and a child, and actually might advocate for increased contact between a child and a caregiver when safety is not a concern. And so CPP really honors that building a secure attachment, even if that relationship is temporary, really enhances a child's ability to build a healthy relationship in the future. So a permanent caregiver is not required for participation in CPP, but it is nice if we know that that child is going to have some length of time, some length of contact with that caregiver, so we can make some progress there. So I want to come back to the points on trauma treatments kind of used within the family. And then our last point here about cultural considerations. So all three of the treatments that we're talking about today address possibly child disruptive behavior to some capacity. And so we want to consider if there's a family that has multiple kids that are involved in treatment, what are potentially the different treatment modalities that might be used across those children. So just to give an example, for PCIT and TF-CBT, both of those treatment modalities take a really structured and directive stance. Whereas in CPP, a clinician is taking a more non-directive and reflective stance. And so if we have caregivers who would be participating in, say, a structured treatment and a non-structured treatment, that could potentially cause some confusion. And I'll talk about kind of a specific example here in a minute, but we want to consider what caregivers might be participating in and what types of strategies they might be hearing within the context of each child's treatment sessions. So to give a more concrete example here, if we have a family who is participating in PCIT for one child and maybe CPP for another child, in PCIT, what a clinician would encourage a parent to do in response to misbehavior is ignore, right? Active ignoring to help shape and provide that differential attention. But in CPP, a clinician would actually encourage attention to a child's kind of dysregulation. And so those are kind of opposite strategies that could be equally effective, but confusing for a parent that might be participating in both PCIT and CPP. So we just want to be mindful of that. And then lastly, kind of returning to the cultural considerations, really this has been woven throughout what we've been discussing all along. We want to make sure that we state this explicitly and create space for really anything within a child and family's cultural experience and lived experience that might not be captured within these components within the framework. There's numerous factors that are related to a child, a parent, and family's lived experiences, identities, culture, and intersectionality that are really important to consider. And we hope you'll offer some grace and benevolence for kind of the brevity of this component, but just know that this is really in the fabric of what you're doing. So with that, I'm going to turn it over to Karin, who's going to walk us through a fictional case example and application of some of these considerations.
Great, thanks, Alyssa. Give me just a moment to get everything situated here so I can see everything I need to. Okay, so as Alyssa mentioned just a moment ago, The case presentation or case application that we're going to be talking about is entirely fictional, and we created it for purposes of this presentation. That's just really important to state out loud, because we're not just offering you clinical material from a real case just for privacy purposes. However, some of the aspects of this case may ring familiar to some of you. In addition, the information that we're providing is very brief, and we did that just for the sake of teaching and time, but know that there's a lot more information if this were a real case that we would all want to gather that would help really inform that decision-making process about the treatment, especially the pieces that Alyssa was just talking about with regard to culture. Now, as we get into this case application, I want to remind you all just of what Kelly said at the beginning. This idea of equifinality and many paths to the same outcome becomes really important. There might be different places that each of you all would come to and different decisions you would make regarding which treatment to pick than I would make, or than Alyssa or Kelly would make. And that's okay, because different factors are going to bubble up differently for different individuals. And so as you're applying this framework, just think about what is more salient to you in those moments. Okay, so let's talk a little about Nadia. So Nadia is 5 years old. She is of average size, and at birth, she had an injury which injured her spine, and she uses a wheelchair. In terms of her language functioning, that's all right on track, so there's no delays or concerns there. Within her family unit, she lives with her 9-year-old sister and her 2 dads. And about 6 months ago, the family home was damaged when tornado-producing winds hit the family's home, and her fathers both sustained pretty minor injuries. Neither Nadia nor her sister were physically injured at all during the event. But since that time, Nadia has been experiencing a variety of different symptoms, including crying, trouble soothing. She has bad dreams about the tornado, and sleep problems that have begun since the traumatic event occurred. She's more irritable. She has more trouble separating from her dads. And she talks a lot about the weather and asks a lot about weather forecasts and whether storms are coming, and just has a lot of anxiety that this type of event is going to happen again. So when clouds or rain are in the forecast, she wants to know about it, and her information seeking and questioning really intensifies. Her dads are also seeking treatment for her sister, and her sister is currently receiving, or just about to begin receiving, TF-CBT. Important to note is that due to some scheduling conflicts, only one caregiver is able to be involved in the treatment for both of the girls. So if you guys have that handout, or can click on that link that Anna Kate made and we dropped in a chat, this is where you would be starting to think about answering each of those questions with regard to the child and the caregiver and the environment. So we'll start with those child factors. So at age 5, Nadia is really appropriate for CPP, PCIT, or TF-CBT. She uses a wheelchair, which doesn't rule out any treatment, but it will require us to be thoughtful about implementing aspects of PCIT, for example. But again, it wouldn't necessarily sway us one direction or another. Her language is right on track, so any of the treatments would be appropriate for her. In terms of symptoms, it seems like she is showing more post-traumatic stress symptoms as opposed to behavioral symptoms. And her symptom presentation seems to be really related to the events that she experienced as opposed to any events that had occurred before. And so we might be leaning more towards CPP or TF-CBT as a result of that symptom presentation. So her behavioral symptoms also seem to be directly connected to the storm. And so, all of this sort of leads us more towards a TF-CBT or a CPP type of focus. So thinking about her clinging behaviors and crying for her fathers and sister kind of makes us think that this might be a fear-based response. And that'll also point us in the direction of TF-CBT or CPP. She also has difficulty soothing, and at 5 years old, young children are often using caregivers to help them soothe. So when we hold that in mind, we want to be thinking about a dyadic treatment that could help her to regulate, a treatment such as CPP, since this really emphasizes strengthening that co-regulatory capacity of the dyad together, okay? So we might be leaning towards CPP in that regard. When we shift from child factors to caregiver factors, we know that Nadia has 2 caregivers who both are supportive and engaged with her, but only one is going to be able to participate in treatment just due to scheduling conflicts. So really, all 3 treatments would still be on the table when we're thinking about that factor. And all 3 treatments are appropriate for use with non-offending and supportive caregivers like Nadia's. Her dads both identify the post-traumatic stress symptoms, particularly that difficulty soothing, the nightmares, problems falling back to sleep, and weather anxiety as the most concerning symptoms at this time. So that really points us towards using treatments such as TF-CBT or CPP. So then shifting and thinking about environmental factors, Nadia's placement is pretty stable at this point. She's got supportive and involved caregivers. So any of those treatment models would be appropriate to pursue with their participation. At this point, she is not in care. So some of the questions that we ask are really not relevant. So we would also want to be thinking about the family's interpretations and meanings and values around trauma, and how traumatic experiences are discussed and how these seem to be in alignment with any of the identified modalities. And another factor that we want to really think about is what else is being used within the family? What other treatment? And Nadia's dads had also expressed as a desire for her older sister to receive treatment. And her older sister's therapist has selected TF-CBT as the best treatment of choice due to her sister's age. And, also given that the same caregiver is going to be involved in both children's treatment, we want to hold that in mind. So given that there are significantly different approaches to trauma treatment between TF-CBT and CPP, it might be most helpful to use a single treatment model within the same family. And so therefore, our team thought it might be the best to use TF-CBT. So we've provided this framework to you, but there's some additional considerations I just want to mention. One is that it's really intended to be used by real people with real experiences with real lives. It's meant to be used by all of you. And so to that end, it's really critical to consider yourself in this process. If you're only trained in 2 models, you might be just choosing between the 2 models that you know. If you know more than 2 models, or more than 3 models, you might be considering all of the different models that you know and how those fit in this framework, and then making your decision. Second, if the framework is telling you one thing, but your clinical gut is telling you another, that's really important information to also reflect on. So I want you to think about why might that be, and consider why you might be feeling pulled in one direction or another, okay? Is it because your clinical gut is picking up on something in the situation that the framework doesn't? Is it due to a bias you might have or something else? The point I'm making is just be thoughtful about what you bring to the table as well, okay? And then lastly, we talked about it as part of the framework earlier, but culture really, really matters. And so as you're applying this framework, be thoughtful about the family's culture and values and how those fit with different models. And then take extra care to ensure that the treatment that you choose actually fits well for the family. And so it's really hard to believe that when we started this dissemination project back in 2009, that you could count on your hands the number of clinicians who were trained in any EBT for childhood trauma. And so what you're seeing on the screen are the names of all the therapists trained in at least one evidence-based treatment for childhood trauma in Arkansas since we started disseminating in 2009. And this might be a little outdated because we're constantly starting and ending cohorts. But as we mentioned at the beginning of this presentation, 140 of these folks have been trained in more than one EBT that we disseminate. And that's really exciting. And we really look forward to that number growing in Arkansas and all over the US and really all over the world. And as more and more folks are trained in multiple EBTs for childhood trauma, I'd love to see a graphic like this for our country and for our world and for others to be thinking about and elaborating on this framework of how do we select the best treatment for each child and family. So I've got some resources up here. You guys can check out the California Evidence-Based Clearinghouse for Child Welfare for more information on how evidence-based treatments are rated and different evidence-based treatments that are available. You'll also see different websites for each of the 3 EBTs we've talked about. We've also got the Our Best website and our contact information. And so we have a few minutes for questions. Anna Kate, do you want me to throw up the code just now?
Yeah, go ahead.
Okay.
So we'll get to some questions here in a minute. For those of you who are needing a CEU, I will be emailing out a survey, a Google form that you can fill out, and then you will automatically get the CEU. Just make sure you enter the code 2702 and you'll get that. Thank you, Karen, Alyssa, and Kelly. That was a really excellent presentation. And we had a few questions come in and that we were able to answer real time. One person was wondering, and I thought, Karen, you could address this to the whole group. How hard and fast are the age rules or the age limits? You know, could someone do PCIT if they were 8 or do, CPP if they were 6? Like how are those things decided?
Yeah, absolutely. And so when we're thinking about these different EBTs, we're thinking about that research base. And so that research base has been conducted with kids for PCIT, for example, ages 2 through age 6 when they start treatment. And so if we're thinking about using it with older kids, there's not something like magic that's going to happen between 6 years and 364 days versus 7 years and 1 day. Really, it's about that research base. And that's where we can feel confident that the treatment that we're implementing is going to be effective. So some of these EBTs yeah, you could certainly use them with some older kids, maybe just a little outside of that age range. However, you're not going to have that research base to really lean back on to say, for sure, I can feel really confident that this is going to work. Now, with PCIT, for example, there's an adaptation for older kids that is currently in the works. It's currently being researched. And so I would look for that in the future, but for now, it's still sort of in development. But a lot of these principles that we're using in treatments like PCIT are just good behavioral principles that can be used with any age of child.
Great. One more quick question. How would you speak to how this decision-making process is made? Obviously, this is a decision for a clinician to make. Some other people involved with the child's case, a caseworker, a judge, they might get this information and think that it's on them to make that decision on which treatment they should go, or recommend a treatment that they've heard of. How do you recommend that a person in that position help the child get the treatment that they need?
Yeah. Oh my gosh, that is such an important question. Yeah. First of all, we love having conversations with CASAs, with attorneys ad litem, with judges, just about how important it is that they're advocating for kids to get services. What we typically recommend is for judges to recommend that the child gets evidence-based care from a clinician who is trained in one of these evidence-based treatments, but leaves it up to the clinician to decide, because the clinician's going to have that expertise and the ability to make the most well-informed decision about what treatment is going to likely work best for the child and family. And also recognize that sometimes new information comes to light and we need to shift course. Sometimes what we pick at the beginning turns out to not be the right fit, and we have to adjust kind of midway through treatment, and that's okay.
Great. Well, that's all the time we have. Thank you, everyone, for participating, and thank you to our presenters. It was a really wonderful presentation. I'll be sharing our slides for today out through an email to everybody. So thank you, and we'll see you next month.
Thanks, everybody.
Thank you.